making sure. All right, so if you think about where you finished your exam, basically with what we did last week, we basically finished with the hand exam with the patient in a seated position. I'm going to try not to block you guys out too much, so if you guys want to get up and move around and come up, I don't mind a bit. I know it might be hard to see from certain parts of the room. But since we're basically at the point where we've completed the hand exam, we've gone through all of the palpation, there were no special tests for the hand, patient's going to be seated on the exam table, and we really haven't changed the patient's position for the entire physical exam so far. So as we move on to the lumbar spine, hip, knee, and ankle, I'll typically go ahead and have the patient stand up for me first. I'll set you down so I can prove that's where we started. Okay. What I'll usually do is have you come stand next to me, if you will. And what you want to do is basically have the patient's feet about shoulder width apart. Keep your knees nice and straight, and I'm going to basically have you reach down and touch your toes for me, or as close as you can get. Okay. And what I'll often do while you're down there, if you can hold for just a second, if you want to evaluate for any abnormal curvature, you go behind the patient and put your hand at the top near the cervical-thoracic junction. Slowly start standing back up for me. And I will often walk down the cervical spine and up the lumbar spine with my fingers to see if the spine is nice and straight or if the spinous processes are off to one side versus another. Now, while the patient's forward, the other thing you're looking at if you're doing a scoliosis check is you're looking at the height of their scapula on each side. It should be symmetric or equal. If a patient has scoliosis, one scapula or the other may be sitting up higher because the spine is rotating into that extra curvature. So we call it a scapular hump, where you'll see one side higher or lower than the other. And there are different ways. There's actually a plastic tool called a scoliometer that you can use to measure for the degree of scoliosis. In most adults, it's not a big deal. In adolescents, in terms of male and female adolescents, so we're talking about kind of 11 to 14 in particular, that's when you really should have scoliosis screening, and it may be part of your family practice routine physical exam, well-child visit kind of thing, okay? Now, if you suspect a scoliosis, you'll often refer them to a spine surgeon, not because they need surgery, but because they need x-rays with specific measurements done so that you can assess the degree of curvature. And then based on age, you can then predict who's likely to progress and have problems versus who just needs routine x-rays for screening versus who doesn't really need to follow it at all. But as part of the head-to-toe checkoffs, you're not going to be doing the scoliosis check, but I just want you guys to have that information, and it should come up again through your training. I just want you to be aware of it. But it's still the same lumbar flexion as we go here. We then do extension. I'm going to rest my hand on the small of your back. Go ahead and arch back for me. Good. Support their back so they don't fall backwards, especially with older patients. You can come back to normal. I will often go around in front of the patient, and then I'll go ahead and say, can you slide one arm down as far as you can go? Good. Come back up to normal. Slide down the other side as far as you can go. Good. Come back to normal. Hands on your hips. Just rotate your upper body around as best you can. Good. Rotate again. Good. Okay, so flexion, extension, side bending, rotation, all of the lumbar spine. What I'll do is I'm going to have her turn around just so you guys can kind of see where I'm going to palpate here. In the lumbar spine exam, while the patient is still standing, probably the best time to do the spinous processes. And what you can do a lot of times is I'll rest my hand on your hips, kind of find the iliac crest, which can be a ticklish spot for some people, so don't push too hard. And then what I'll do is I'll work my way towards the midline. You typically want to expose this area so you know where you're at, see if there's any skin abnormalities or otherwise. But I'm on the spinous processes right now, kind of on the upper lumbar spine, and you're just walking down those to the sacrum at the top of the gluteal cleft. Okay, you don't have to go down the entire sacrum or any further than that. While you're here, because some of your palpation landmarks are on the back side, I recommend palpating iliac crest, since you already found it while you were here. And then if you reach across, where your thumbs have a tendency to fall, is almost always right on the SI joints. So you can palpate the SI joint on each side, and you can usually feel a little indentation or dimple right where the SI joint is at. What you might feel instead would be the tubercle back here, and then you just move a little more medial to it and you drop over the edge of it. So that's SI joint. Now while I have her here, one thing you may want to do is say, okay, I need to go ahead and palpate the ischial tuberosity. If you can for me, can you go ahead on your left side and poke on your butt bone for me? How about your other left? Just kidding.
I don't know.
Are you feeling a bony bump?
No.
All right, pardon my reach. I'm going to poke on your bony bump. I'm going to find it. So you kind of have to poke in there kind of hard, and that's why I always say it's better to ask the patient to try to find it first. If you can't find it while they're standing up, while they're sitting down, you can actually slide underneath and palpate on that bony bump as well. Sorry. Now, once you find that, pardon my reach, you can go off to the side, and the sciatic nerve is going to be kind of deep in the buttock, but lateral to that bony bump or that ischial tuberosity. So even though this is combining lumbar spine and hip exam together, you've got the patient standing up where you can get to all these things, and maybe better to go ahead and do it while you have them in that position. So on your new checkoffs, which you guys want to start passing these around. I'm going to start them down here. If you guys can just pass them all the way around. There's some things that are going to be in red, and it just gives you some options of which way you can do this. I've got it. I'll steal it over here. All right. So after we've done the palpation there, I'm going to have you go ahead and sit back on the edge of the bed for me. A seated straight leg raise is a test for nerve inflammation or irritation. With the patient sitting here, all I'm going to do as the examiner is I'm just going to passively lift you up. You let me do it. Sometimes patients, if the nerve is irritated, they'll start to lean back. A lot of times I'll rest my hand on the shoulder to keep them from leaning back too far. And then I'm going to lift up a little bit. If that causes any unusual sensations down to your feet, let me know. Okay? Most people feel stretching in their hamstrings when we do it. Okay, stretching is not a positive seated straight leg raise, but if they say no, it's causing pain, they're pulling away from you, they're describing numbness, tingling, anything shooting down to their foot, that's nerve irritation. That's that lumbar radiculitis, nerve irritation. Okay? So that's simply a seated straight leg raise. What I'll have you do, if you will, I'll have you lie down on that end, on your back. The supine straight leg raise is basically, supine straight leg raise is basically the same test, and what you do is you just keep the knee nice and straight, you bring the leg up. Any unusual sensations? Getting some stretching?
Yep.
Okay, good. We'll hold it here for a while and torture it. But a lot of times when you start to do this, a patient will often, the pelvis will often move because of the pressure they're feeling from the nerve. So straight leg raising there. Now, don't get me wrong, if I crank on her foot and pull it down, she's going to feel pain in her calf. That's why we don't pull down on the foot at all. We're basically just trying to isolate the lumbar nerve roots. Okay? A lot of times you can test hamstring flexibility in this position as well. Since she's already in this position, this is where I said it's worth doing the Faber test. So what you do is you as the examiner place the patient in a figure 4 position. I'm testing right now her left SI joint. Hand on the top of the pelvis. So now, kind of on the ASIS, or the anterior superior iliac spine, I'm holding it there. I'm going to push down a little bit on your knee. Let me know if it causes any pain at all. Any pain at all there? Okay. If she said she had pain, you would want her to elaborate and tell you where she feels it. Some people will get that in the groin. That's not a positive Faber. If she says it hurts back in here, that's positive Faber because that's more at the sacroiliac joint. Okay? So you as the examiner are stabilizing the pelvis, hand on the knee, pushing down. Okay? All right. All right, so while your patient is still supine, you can move on and do your hip exam. I'm going to try to let you guys see as much as we can. While she's in this position, I want you to go ahead and just bend your knee and pull it up towards your chest. This is hip flexion. Go ahead and straighten it back out for me. Good. We're not doing hip extension. Make sure you cross it off if it's still showing up anywhere. Hip adduction is basically, have you lift your leg up in the air, swing that leg across your body, good, come back, and then we're tight here with this, but swing your leg out to the side, keep your knee straight if you will, and just kind of swing it out. So that's hip abduction, away from her midline. Adduction is toward the midline or across the midline, okay? And then you can help your patient up into this position. I want you to go ahead and try to rotate your knee outward and pull your foot inward. That's hip external rotation. Keep your knee there. Drop your knee inward and rotate your foot. Hip internal rotation. Okay? And sometimes patients have a hard time following instructions. She's doing good. What I'm saying though is sometimes you have to go ahead and do it for them and check them passively because you just don't know if they're going to understand what you're saying. Okay? So a lot of times I'll take them up into that as well. Now, in this position, we're going to go ahead and I'm going to actually sit you back up as we go. Got it? Come on out to the edge for me. Is for resisted hip motions. I like to do it with them seated. So we've been doing the left side. If you want to come around, you can.
Yeah.
Go ahead and just pull that knee up in the air. Hold it up. I'm going to pull down. Don't let me. This is resisted hip flexion. Okay? But obviously, we're doing everything bilaterally, so you just want to keep verbalizing that throughout your exam. Hip abduction. I want you to spread your knees apart. I'm holding her knees on the outside. She's pushing them both out, so you're testing them both at once. Then you put your hands inside the knees. Go ahead and squeeze my hands together. Good. Hip adduction right there. So that's your resisted hip motions. And I really think it's easier to do the resisted hip motions in that seated position. You're not doing any resisted internal or external rotation on your checkoff, so you don't have to worry about that. Now, in this position, even while she's seated, you can get to your landmarks for the hip. We already palpated iliac crest and did everything posteriorly. So on the side of the hip in here, greater tuberosity in here, pardon my reach around the front, anterior superior iliac spine in the front, and any other hip landmarks on the list. You guys haven't had a chance to look at a bunch, but you can at least get those from that position. We've got them all there. We already did the Faber test because we did it in the lumbar spine. And then you already have the patient in a position to do your knee exam. Okay? So visually, you're going to inspect. You guys don't have to document all that. The knee basically is flexion and extension. I'm going to have you go ahead and straighten that right knee out for me. Extension. Bend it back as far as you can. You can always pull it up towards your chest if you need to, just to test full flexion. Okay? So we've done flexion and extension. Now I'm going to have you push out towards me like you're trying to straighten your knee. Resisted knee extension. Pull back like you're going to bend it back. Resisted knee flexion. And then we move on to palpation, if I may. Pull this up above. She's like, you already poked in my butt though. Poke on my knee. All right, so I like to do it kind of systematically where we start on the front and then we move medial and then we move lateral, and that way you cover all your structures. So palpation-wise, you're going to start with the patella. Usually start up top and kind of walk your finger along the patella, down to the infrapatellar tendon, down to the tibial tubercle. Okay? Now, in front of the patella is the prepatellar bursa, which of course hers is not inflamed, so it's flat. We'll go lateral first. Find the soft spot on each side of the infrapatellar tendon, and then walk your fingers across. So I'm on the lateral joint line, which is also where the lateral meniscus is at, and you're walking all the way around to the back. The lateral collateral ligament attaches to the lateral epicondyle and comes down to the fibular head. So that's lateral collateral ligament. And then the IT band comes down and attaches to this bony bump right here, the lateral. So this is Gertie's tubercle. We'll help you guys find that this afternoon. But that's where the IT band comes down. So medial side, find the soft spot. You're on the medial joint line. Walk around and usually use 2 fingers and kind of go around the whole joint line. And remember, you want to put enough pressure that you're basically pushing some of the blood flow out of your fingernails, and then you'll know you're putting enough pressure. So on the medial joint line and the medial meniscus, go up to the medial epicondyle. That's MCL, medial collateral ligament coming down. The pes bursa sits right below that and is sometimes a little sensitive on folks. If someone says it hurts when you poke on it, always check the other side and say, well, does it hurt any more than it does over here? That way you can tell if it's really painful or if it's just a sensitive tissue in general. All right? And then as we move around to the back of the knee, there's the popliteal fossa back here. That's in the back of the knee, and you're basically feeling whether or not there's any mass or cyst or anything unusual back there. I think we've got all the landmarks for the knee. Let's make sure. Yep. All right, so special tests. I will have you go ahead and lie back down for me, please. We do have to put you lying down for these. I'm going to switch it up just so I can demonstrate. The knee tests that you guys need to know are basically varus and valgus with the knee at 0 or completely straight. You rest your hand on the outside of the knee and basically put a valgus stress on the knee and pulling the foot outward, pushing the knee inward, putting stress on the MCL. That test should be done at 0 straight, and it should also be done a little bit at 30 degrees, a little bit of a bend, and repeat. You want to know if it causes pain or if there's any laxity or looseness of it. To do the other side, we do a varus stress. Now I've got some of you boxed out. Basically pulling the ankle inward, pushing the knee outward, testing the lateral collateral ligament at 0 degrees, and again at 30 degrees. Okay, so that's valgus first, and then varus stress testing. Valgus testing for MCL, varus stress testing for LCL. Lockman testing, this is going to be better to do kind of hands-on this afternoon, but I'm going to show you. What you want to do is basically support your patient's quad or thigh and get a grip on the thigh as best you can. This is the one where I said you don't have big hands, or if you have a larger patient, you can't get your hands around them, you may have to do an anterior drawer instead. For this, I can get my hand around hers, I'm supporting her thigh, and I want her to relax as much as we can. I'm going to support the lower leg, and what I'm doing is I'm stabilizing the thigh by gripping it, stabilizing the tibia by gripping it, and I'm pulling the tibia anterior. There's no play in there. Okay? So if I couldn't get a good grip on her leg, I would put her up to 90 degrees. I would go ahead and sit on her foot a little bit. Relax as best you can. You can feel the hamstrings and whether or not they're relaxed. And I would do it pulling out towards me with both for an anterior drawer. Okay? So no excessive play there, but those are both tests for the ACL. So you have the ability to do the Lockman. If you can't do it based on a limiting factor, you can do the anterior drawer instead, but you should still verbalize Lockman when you guys do your checkoffs. Okay? A test that I did not mention is called a allotment test. This is basically a situation where you kind of put your hand up above the patella and the suprapatellar pouch. You push down and kind of milk any fluid that may be in the knee towards the kneecap itself. And then all you do is push down on the kneecap, just gently, to see if the kneecap is kind of floating up because of extra fluid. This is important if we're talking about, does a patient have an effusion, meaning fluid intracapsular, versus is it just swelling maybe in front of the kneecap or somewhere else? This will tell you if the fluid's from inside the knee or not. McMurray testing, we'll do it in individual groups just so you guys can see it and see why we test it all. All right, grab on, bring you back out to the edge of the table, and hate to do it to you, but can we lose the sock and shoe on the right side just so you can demo? All right, so from an ankle standpoint, I like to start posteriorly and walk down the gastrocnemius complex into the Achilles tendon. So you need to palpate Achilles tendon, calcaneus. I'll go with the medial structures first, which might be hard to see, but you want to palpate the medial malleolus, or the bony bump on the medial side of the ankle. And then directly below that, wrapping around underneath it, is the deltoid ligament. Since we're on the medial side of the ankle, walk down to the navicular bone. It's that little bony kind of prominence right here. That's the navicular bone of the foot. We go lateral side, we've got the lateral malleolus right here. If you walk straight down off of that, you're going to be on basically the calcaneofibular ligament. If you come forward on that lateral malleolus, you're going to get more into the anterior talofibular ligament, the most commonly injured ankle ligament. And then the other ligament we were talking about is actually even further forward and up a little bit. It's the connection between your tibia and your fibula, called the distal tibiofibular ligament. That's the high ankle spread. So you're going to work your way up the ankle a little bit with that one. While you're on the outside or lateral side of the foot, go to the base of this bone. That's the base of your fifth metatarsal. If you walk back towards the lateral malleolus, you're in the peroneal tendons. So you can palpate them here if you want, or you can go behind this bone and verbalize peroneal tendons, because they do wrap around that direction. Working out towards the foot itself, in the metatarsals, You're going to basically get thumb and index finger. I'm on the 5th metatarsal head, the 4th, the 3rd, 2nd, and 1st. We've got, I don't know if phalanges are officially on here or not. I don't think they are, which is good. Good. All right. And then we go to just one special test for the ankle. It's called an anterior drawer, and it's a test for the anterior talofibular ligament to see whether or not the ankle is unstable. And you basically support above the ankle and grab around the heel and foot. Try to get your patient to relax a little bit. You can even move it up and down just to kind of get them relaxed. And then what I'm doing is I'm basically pulling forward. See that? I don't know if you can see it on her, but it's got a little bit of play in this ankle. So maybe an old ankle injury, or maybe just be the way the good Lord made her. But the key is whether or not it hurts, and then whether or not it's symmetric. So you understand. Okay? Stop. We good? That's the extension of the exam. Went through it kind of slow and verbalized why we were doing a lot of stuff.